श्वेत पद्मासना या ब्रह्माच्युत शङ्कर प्रभृतिभिः देवैः सदा वन्दिता सा मां पातु सरस्वती भगवती
Very warm welcome and good evening, one and all. First of all, I, Pandit Patil, would take this opportunity to thank you, the entire medical fraternity who has been constantly trying to save the human lives from this deadly pandemic. To curtail the impact of COVID-19 amongst all, the social distancing is one of the actions which we are strictly adhering to. Therefore, we have organized this virtual webinar through virtual mode, which will maintain your safety while you share your in-depth knowledge and immense experience with us. Dr. Sahi, I would like to thank you for accepting our invitation to join us here. And I'm sure that your august presence and active participations during today's webinar will further augment the sessions of this webinar. Doctor, you are always garnered trust and warmth upon us, and we seek the same in the future as well, especially during this period of uncertainty. So, let's welcome today's speaker, none other than Dr. Rakesh Kumar Sai, who is the professor and head of Department of Endocrinology, Usmania Medical College and Hospital. Doctors is a Vice President and Endocrine Society of India and Vice President South Asia Federation of Endocrine Societies. Dr. Sai is a former Secretary and Endocrine Society of India, a Founder Secretary South Asian Federation of Endocrine Societies, former Chairman of the AP chapter of RSSDI and Hyderabad chapter of the API. In addition to that, Doctor is Associate Editor of Indian Journal of Endocrinology and Metabolism. Dr. Sai is awarded with the Fellowship of American College of Endocrinology in 2009, a Fellowship of RSSDI 2015, even Fellowship of the Indian College of Physicians in 2006, apart from Fellowship of Indian Academy of Clinician Medicines 2008. A doctor is a head senior lecturership orations of Association of Physicians of India for 2008. And there are many publications on the name of the Dr. Sai. One is over 130 publication in various national and international journals. And doctor is authored chapter in various textbooks and monograms on diabetes and endocrinology. With these small introductions about the Dr. Rakesh Kumar Sai, I request Dr. Sai to start the today's presentations. Over to you, sir.
Thank you. Good evening to all of you and I thank you for being here and thank Torrent for organizing this this program for us to interact. Speaking on mainly about management of hypertension in patients with diabetes. This is a very major issue of managing hypertension. It's equally important as managing the diabetes itself, or rather more important than managing the hyperglycemia itself. So managing hypertension in a diabetes is really a challenge. And I would be discussing about the broad concepts about management of hypertension and discuss about the role of Telmisartan, particularly in this context of managing patients with diabetes with or without complications, particularly with respect to their blood pressure management. So I thank all of you for being here and on this occasion, in this peak time of the day when you are all, I'm sure, are busy and or just got free from your practice. I'm sure you have been busy throughout the day. And I thank you all for being here and spending your time here. And I thank Torrent for giving this opportunity. So what I would like to do in the next, say 20-25 minutes or so is discuss about what the blood pressure thresholds and guidelines are from various organizations, and discuss about the role of ARBs. Particularly, these are a very important and very useful class of drugs, particularly in managing hypertension in patients with diabetes. So I'd be discussing about the development of these ARBs, different ARBs that we have, and then narrow down to Telmisartan particularly, because that's the one which many of us use, and use it very commonly in many of our patients. And also, then what I would try to do is discuss about some of the landmark studies of Telmisartan that are available, and the key evidences that are there in terms of the benefits of Telmisartan in managing blood pressure, and then go on to discuss about what the guidelines are saying, particularly with regard to the to how to diagnose hypertension, and how to and what should be the target for managing blood pressure in patients with diabetes. Finally, I'll end with some unique features about Telmisartan in this context. So we all know that type 2 diabetes, the epidemic of type 2 diabetes is increasing worldwide. And we have a huge number of patients with diabetes. Today, we have 7 crore people with diabetes across our country. And we know that managing blood pressure, blood sugar brings down, for every 1% reduction in HbA1c, we know from the Wikipedia study that every 1% reduction in blood pressure brings down the complications by almost 30%, and they have a very significant effect. The glycemia has a very significant effect on the endothelial dysfunction, that is the vascular endothelium, how it works. That is influenced by the glucose levels, and thereby there is significant improvement in the vascular complications also when you bring down the blood pressure. So now the other aspect is that from the same Wikipedia study, we also came to know that managing the blood pressure gives you better results and faster results, gives you results much faster, and to the same extent you have very significant improvement in the risk of complications by managing your blood pressure itself, blood pressure and effective management of blood pressure. So this is why blood pressure control is very important, and that's the reason why we know that blood pressure control is very important. And we know that the changes in the endothelial function and the extracellular matrix, which are brought about by the hyperglycemia itself, can alter the vascular function, leads to arterial stiffness, loss of elastic recoil, and decreases the vasodilatory capacity of blood vessels. And that is why blood pressure develops very commonly in patients with diabetes. And today we know that at least 60 to 70% of our patients with diabetes have blood pressure. And it is very important to identify that, recognize that, because many times we are more focused on the glucose levels, and we forget to look at the blood pressure. We should identify hypertension early and treat it effectively, so that we get the maximum benefit in terms of preventing the complications of diabetes. So the various reasons for blood pressure are not only the hyperglycemia, which acts on the endothelium and causes endothelial dysfunction. It's also the insulin resistance which is there, which is causing the higher insulin levels, which have this effect on the arterial wall, and also several other factors, that the fluid retention that is brought about by insulin. So all these factors play a role in the development of hypertension. The arterial stiffness not only contributes to end organ damage and increases the risk of cardiovascular events. Hypertension and diabetes together contribute to the arterial stiffness, and poor control of blood pressure worsens the damage that is caused because of diabetes. So it is very important, as I've shown the data I've mentioned about the data from the Wikipedia study. Now let us look at how do we diagnose blood pressure, because it's important that we should identify it early. As I said, we should identify it early. When should we call a person with diabetes as having hypertension or not? So definition. However, there are little differences between different organizations across the world in terms of their labeling of what hypertension is. So, if you look at the definition of hypertension, the ACC/AHA, that is the American College of Cardiology and the American Heart Association, say that anybody who is having a blood pressure more than 130/80 should be called a hypertensive. Whereas on the European side, you say that the corresponding organizations on the European side say that 114/90 is the cutoff that should be used rather than 130/80. So whatever cutoff you use, but what we see is that although there is a little difference of opinion on when you should start treating, or when you should label the hypertension, all of them have very similar views on how you should treat it and what should be the target. So if you look at identifying hypertension, they also have a little bit of this thing difference in terms of the staging of hypertension. The ACC, AHA say that stage 1 and stage 2. They're saying stage 1 and stage 2, whereas on the European side, they're speaking of grade 1, grade 2, and grade 3 when it's more than 180 by 110. And they have also highlighted the fact that at different ages you have different cutoffs for the blood pressure targets. So more or less, but you can see more or less the target is 130 by 80 across different ages. And in younger people, although the Europeans say that you can go down to about 120 to 129 also, can be a target in people less than 65 years of age. Whereas above 65 years of age, it should be generally more than 130 to 139 being an optimal target for the systolic blood pressure. So this is how there can be some differences, but broadly, I mean, the opinion is more or less the same. So as you can see again, this slide also shows the gender differences. I mean, the guideline differences. That is in terms of the American versus the European guidelines in terms of defining different types of BP measurements. Also, they have also said that for the office BP or the clinic BP, you may use 130 by 80 as we have just discussed, 140 by 90 from the European side. But when you look at the home BP monitoring, they are more or less same, 130 by 80 on the American side, same as what they're saying for the office BP, and 135 by 85 and the Europeans are saying of that. Speaking of that, so this is what we are seeing, that there could be slight differences. Particularly, the confusion may arise when somebody is having a BP between 130 to 140. You may want to see them, check them again and again to be able to be sure. So to be sort of confident that they are diagnosed as hypertensive. But if you look at the 24-hour mean values, the values are little lower. At little lower values also, you may actually identify hypertension. And if you look at the nighttime values, as you know that nighttime there's a dipping of blood pressure, so we use lower cutoffs for identifying hypertension. So the importance is that taking BP at home is very important. From all this discussion that we've seen, taking BP is very important, and having a home blood pressure monitoring device is very important for patients. You should encourage them to do that, and they should bring the BP machine for annual calibration or validation of their readings. And the other important thing is that we need to sort of see that they frequently monitor BP, and those readings can be used for deciding our therapy. Now let us look at this heat map, which is showing us that when your BP is high, along with the presence of comorbidities, as you can see on the right side is grade 2, grade 3 blood pressure, and on the left side you can see the step 1 with comorbidities. As you can see, stage 2, where there is presence of CKD or hypertrophic cardiomyopathy or all these other conditions that are there. What happens is that the risk for cardiovascular, the risk for CV risk keeps increasing, therefore you're saying that those people who have hypertension along with other comorbidities, they are tending to be at greater risk of cardiovascular disease, and even diabetes actually puts them in stage 3 or puts them in a very high risk, as you can see diabetes on the lower panel. So essentially this chart tells us that when hypertension is present alone, that's it, the risk is probably lower. But when it is present with cardiovascular disease or CKD or with diabetes, then the risk for vascular events is much increased. Now let us look at the ARBs. ARBs are a very useful class of drugs for the management of hypertension, and they were introduced in as early. I mean, as you can say, about 3 decades back in 1990s. We had the first one was probably captopril. Captopril is not shown here. The first one was losartan, which was compared at that time. We had the live study which brought out about which studied the role of losartan in terms of cardiovascular event. Then we had valsartan, which came in. Then we had irbesartan in 1997, 1998. Telmisartan came. So Telmisartan is with us for almost now 22 years, and we have a good experience in using Telmisartan, and it has stood out as one of the best ARBs till now. And then we have azilsartan, which has come in very recently in 2011, And so this is how the ARBs have evolved. We have got 6 or 7 different ARBs. There are some more ARBs which have not become very popular. Telmisartan was one more which came into our country but did not become very popular. So these are the different evolution path of the ARBs. And if you look at Telmisartan, it has the longest plasma half-life and the largest volume of distribution because it has got a lipophilic activity. It is lipophilic and crosses the blood-brain barrier. It has got a large volume of distribution, and therefore it has got a long plasma half-life. Because of this, it has got several advantages. And another unique feature about telmisartan is that it has got a PPAR gamma agonist activity. That is, it has got activity. So therefore, it is preferred for all the diabetic hypertensives. As we know, the PPAR gamma are important ligands which regulate the glucose and lipid metabolism, and also several intermediate metabolism pathways are regulated by the PPAR gamma system in the nucleus of the cell. So so what we see is that telmisartan, because of its action on the PPAR gamma, has improves the insulin sensitivity, and it also increases adiponectin activity and reduces inflammatory markers. So it has got several of these benefits which add on to its antihypertensive effect. So apart from the blood pressure reduction, these are the additional benefits that we're seeing, and that's the reason why we are saying that telmisartan stands out as a good cardiometabolic sartan, as we can say. So it blocks the angiotensin pathways, as we all know. This is the primary mechanism of action which we know, but it also has, because of its activation of PPAR gamma pathways, it has a modest effect on insulin resistance. It may not be a great insulin drug for insulin resistance as much as metformin, but it has some effect which is definitely added on to the effect of the other anti-diabetic medications, and it has got a definite benefit as you compare edge over other sartans. Then it has got an effect on dyslipidemia, effects on cell inflammation, cell proliferation through its effect on the PPAR gamma pathways. And while its major action is by blocking the angiotensin pathway, as we all know. Now, so because of this, it has favorable effects on all this and reduces the cardiometabolic risk. So it works across the entire continuum of CV risk, that is in patients with low CV risk versus a patient, and also in patients with high CV risk. It works very well, and it has beneficial effects in terms of improving the vascular function, improving the endothelial function, reducing the dyslipidemia, reducing the insulin resistance, having a beneficial effect on cardiac remodeling, and thereby reducing CHF and strokes and cardiovascular events. So, and it's one of the only ARBs which has got a 24-hour BP reduction effect, and it reduces the triglycerides, reduces the LDL cholesterol, and has a small effect of increasing the HDL cholesterol also. Although these effects are not very prominent, but they add on to the benefits of the blood pressure reduction of telmisartan, which is brought about. These effects also add on, and thereby actually we give it an additional edge in terms of reducing the cardiometabolic events. And so as we see, it improves the. So let me now show you some studies which have shown that there are beneficial effects on inflammatory markers, reduction in cardiovascular events, and how it is useful in management post stroke and post MI, and in all these situations how it is. So I'll just show you some studies to look at these benefits. Now let me show you the first study which looked at, because in the late 90s or and the early 2000s, what we had was a lot of evidence for the ACE inhibitors. ACE inhibitors also are acting on the RAS pathway only. So we had a lot of evidence with ramipril as a drug which had great cardiovascular benefits. And this study, the on-target study, was a landmark study because it compared telmisartan with ramipril and looked at and it also, this study also had one more arm, a third arm, which had both telmisartan and ramipril. So what it showed was that this on-target study basically was the primary objective of the study was to compare between telmisartan or ramipril, and it showed the non-inferiority of telmisartan as compared to ramipril, showing that they are almost equal. They are almost equal in terms of the cardiovascular benefit that is present. That whatever benefit ramipril had is also seen with telmisartan. And however, there was also some additional points that came out of the study. that telmisartan, as compared to ramipril, had a slightly greater reduction in the mean blood pressure in the telmisartan group by zero point 0.9 systolic and zero point 0.6 diastolic greater over a period of 56 months of use. And it was equivalent to ramipril for the primary outcome. That is, the primary outcome was a composite of death from cardiovascular disease, myocardial infarction, stroke, or hospitalization for heart failure. And it was equivalent to with ramipril in terms of vascular disease or high risk diabetes, and was associated with less angioedema. And another important message that came out of all of this study was that there is no benefit of combining ramipril with telmisartan, and that is the landmark information that came out of this study. After which we have stopped combining these two. Otherwise, we used to often combine these two drugs, that is the ACE inhibitors and the ARBs, expecting greater benefit by combining that. And what came out of this study was that there is greater risk of hyperkalemia and more of problems rather than benefit of combining these two drugs. Now let us look at other drugs, like other studies like the Transcend study, which was telmisartan randomized assessment study in ACE intolerant subjects with cardiovascular disease. So in patients who were taking ACE inhibitors, who were intolerant to ACE inhibitors, they were shifted to telmisartan, and what we found was that the primary outcome came down by about 8%. There was significant reduction in the main secondary outcome of CV death, MI, or stroke by 13%. This became statistically significant while the primary outcome did not reach statistical significance. And the important point was that it was well tolerated. There was no excess of adverse events, particularly the angioedema and the cough that happens with ACE inhibitors was not seen with telmisartan, and it had the cardiovascular benefits that were seen with the ACE inhibitors also. Another trial called the Profess trial, what it did was, look, it had more than 20,000 patients who were randomized to getting either telmisartan or placebo in combination with other agents like clopidogrel, aspirin, and all the other agents required. And they followed up for 2.5 years, and they found that this was basically looking at people with a ischemic stroke in the background. And what they looked at was the recurrence of stroke. The rate of first recurrent stroke was the primary endpoint, and the secondary endpoints were development of apart from development of stroke, myocardial infarction, vascular death, rate of new onset diabetes, and tertiary endpoints were major hemorrhagic events, all death, new or worsening congestive heart failure. So these were the endpoints that were defined for this study. And after 2.5 years of follow-up, it was seen that there was a favorable effect seen in all the cardiovascular events in terms of the cardiovascular events, although they did not reach superiority. I mean, they didn't show that telmisartan was very superior in terms of this, but it did reduce all these events. There was a trend favoring improvement in all these parameters with the use of telmisartan, and similarly for the cardiovascular events, not only for the cerebrovascular events but also the cardiovascular events, there was a benefit in terms of use of telmisartan as compared to placebo. So the therapy with telmisartan initiated within 10 days after ischemic stroke and continued for 2.5 years lowers the rate of recurrent stroke, major cardiovascular events, or diabetes. So this was the major conclusion from this study. Then we have the Team Star 5 study. This was basically looking at how it is in terms of combining telmisartan with amlodipine. We know that amlodipine is a very potent calcium channel blocker, and telmisartan is one of the best amongst the ARBs. So a combination of this versus increasing dose of amlodipine. So in patients who were not controlled with amlodipine, the option was to either increase the dose of amlodipine from 5 to 10 milligrams or add telmisartan 40 mg or 80 mg. So this is what you can see. The four arms in this study are showing that that is the first one is telmisartan, amlodipine 5 mg. Second one is amlodipine 10 mg. The third bar is amlodipine 5 mg plus telmisartan 40 mg, and the fourth one is amlodipine 5 mg plus telmisartan 80 mg. So as you can see, the best reduction in blood pressure of more than 15 millimeter of systolic and 10 millimeter diastolic was seen with the combination of 80 milligrams of telmisartan and 5 milligrams of amlodipine. So increasing the dose of amlodipine alone is not going to be good because it increases the risk for development of peripheral edema, causes those problems, tolerability becomes an issue. But when you combine it with telmisartan, the edema also comes down, and then you have better reduction in blood pressure, as you see in this study. So then we have combinations of use fixed dose versus using usual care. So this was one study which was published in JAMA in very recently, 2018 only. What they did in this study was, this was from Sri Lanka, 11 urban clinics in Sri Lanka. They had 297 men and 403 women, so about 700 patients who were randomized to either a triple pill therapy, that is low dose, a single pill having all the three medications, that is 20 mg of telmisartan, 2.5 mg of amlodipine, and 12.5 mg of hydrochlorothiazide. So this is a small low dose combination as compared to usual care, where you start with one dose and then one medication, increase it, and then go on to increase it. So what they found is that 70% of patients with hypertension could be controlled with this triple low dose pill as compared to patients who were on usual care. So usual care was where they could add on liberally. The clinician could add individual agents as they required. So what they found was that when they did that, 55% of patients only could reach the target, whereas with the triple pill combination started initially, 70% of patients reached the target. So this is indeed a good, remarkable benefit. Now we have some studies. I'll quickly show you some studies. Attempt CVC study looked at cardiac biomarkers and with different doses of telmisartan, starting with 20 mg, going up to about 80 mg, and with along with other concomitant medications. What they looked at was the biomarkers. They looked at was the urinary albumin creatinine ratio and the plasma brain natriuretic peptide. So the BNP level goes up in in people with hypertension, and also in people with age. Whereas here and the USCR also goes up as the duration of hypertension increases. So what we found was that the group that was receiving ARB tended to have lower USCR and lower plasma BNP levels. So definitely, telmisartan has a benefit in terms of reducing the urinary albumin creatinine ratio and albumin excretion in terms of the ratio that we're seeing, and also reducing the BNP levels. So thereby, it has a significant benefit in terms of improving the cardiovascular events because of these benefits that you can see. Now, there's another study called the Trendy study, which compared the telmisartan versus ramipril renal endothelial dysfunction. So what we see is that the adiponectin levels came down with the use of telmisartan, and went up. I mean, adiponectin is a protective molecule, as you know. Adiponectin, as compared to all the other cytokines, is protective. Higher levels of adiponectin are seen in healthy individuals, and patients with diabetes and other disorders have lower adiponectin levels. And what we find is that with the use of telmisartan, you could see the adiponectin levels being higher, as you can see the black bars, and the lighter bars are the ones who are using ramipril, and they did not have as great benefit with telmisartan, with the use of ramipril in blood pressure reduction as was seen with telmisartan. So definitely a better effect on improving the uh, endothelial function in terms of as measured by the adiponectin levels or measured by the nitric oxide activity, as was also done in this study. Then we have another study which looked at proteinuria, serum creatinine levels, and EGFR, and showed that telmisartan had a better role in terms of preserving the EGFR, improving the EGFR by almost 24% improvement in EGFR, reduction in serum creatinine by 18%, and proteinuria coming down by 19%. So these studies have definitely shown the molecular mechanisms by which telmisartan is bringing about the cardiovascular benefit, and this was a use of telmisartan after Zutarilimus eluting stent implantation in hypertensive patients who were also diabetic. And what we find is that with the use of in patients who were getting telmisartan versus, and this was a comparison between telmisartan versus valsartan, and we find that there was less of in-stent stenosis as compared to those who were not getting this molecule. So it reduces the neointimal volume, atherosclerosis progression was reduced, and independent of the blood pressure reduction, there was some benefit on the glucose and lipid control in hypertensive patients. So what we are seeing is that here again, it was compared with carvedilol in terms of prevention of atrial fibrillation, and it did show some benefit in terms of preventing the recurrence of atrial fibrillation in hypertensive patients when they were given telmisartan. And then we have another study which had looked at patients with type 2 diabetes with or without complications. What is the effect of using telmisartan in patients with or without complications of diabetes? So as you can see, Those without complications are the ones in blue, and then those with complications, as you can see, all the other distribution of patients. So there was a wide spectrum of patients who had various complications, and there was a small group which did not have any complications. And if you look at the patients who had complications, also, I mean, the use of telmisartan in this group was done, and let us see what was the benefit that was seen. As you can see, the with the use of telmisartan, what we can see is there was a better reduction in blood pressure. Even in the group that had complications, you had a significant fall in blood pressure, which was similar to the group that did not have complications, and both the systolic and diastolic blood pressure reduced to the same extent in both the groups. That is, with complications or without complications. We know that when the complications are present, the blood pressure goes up very high, and sometimes the management of blood pressure also is difficult when there's renal disease. So here you find that even with the presence of renal disease or the presence of cardiovascular disease, the management of the blood pressure reduction was similar with the use of telmisartan in both the groups. And telmisartan was associated with significant reduction in systolic as well as diastolic blood pressure over 12 weeks of treatment. There was significant blood pressure reduction, which was noted even after the first 2 weeks of use. So within 2 weeks of use, you could see that the patients were reaching their targets, and there was a beneficial effect on the blood glucose and weight, probably due to improvement in the, and also this resulted in improvement in the vascular health. So what we see is that telmisartan is a good choice in patients with diabetes, whether they have complications or no complications. So let us just look at what we've understood from all these studies is that telmisartan has got several benefits. That is, apart from its angiotensin receptor blocking effect, it also has and its lipophilic activity and its long plasma half life. It becomes the best agent in its class, and it is the only one which has been shown amongst the ARBs to reduce CV morbidity in a broad spectrum of patients with a wide spectrum of cardiovascular risk. And it is also one of the most widely studied sartan or the ARB for effect on cardiovascular outcomes. So what we see is that if you look at this chart, this is a chart which was published in cardiovascular diabetology and what they looked at was that whether in 2012, and they charted out the different benefits versus risk in different scenarios of the various drugs. And as you can see, ARBs as such stand out as very good drugs for uncomplicated hypertension, those with renal dysfunction, those with proteinuria, those with metabolic syndrome, those with diabetes, and only for isolated systolic blood pressure, probably we can say that the best drug is calcium channel blockers in ARBs, maybe a little lower in order in terms of reducing the isolated systolic blood pressure. And combination containing ARBs rather than ACE inhibitors may be preferred because ARBs are having a superior tolerability, which will improve the adherence also. And in patients with type 2 diabetes with proteinuria and renal insufficiency, ARB-based treatment is recommended because these agents delay the progression of nephropathy also. This has been shown in several studies that the renal study, the many other studies like that have shown that there is a benefit on progression of nephropathy also. As I also showed you some data in the previous slides about the reduction in proteinuria and reduction in the creatinine levels and increase in GFR. So in hypertensive patients at increased CV risk requiring antihypertensive agents that specifically reduce blood volume, the combination of ARB along with a thiazide diuretic may be the best choice because it reduces the blood volume and it reduces the cardiovascular risk factors. Now let us look at what the recent guidelines are saying, having looked at all the studies which have shown the various benefits of telmisartan, that is in terms of the cardiovascular risk and in terms of the various effects on metabolism and on the inflammatory markers. I will now go on to see what the guidelines are showing. So if you look at the strategies which have been suggested for management of hypertension, if you look at the European Society of Cardiology in the recent guideline in 2018, what they said is that you should, when you have blood pressure, which is when the systolic blood pressure is more than 150, or if you are dealing with the blood pressure which is more than 20 millimeters, when you want to reduce it more than 20 millimeters mercury systolic and 10 millimeters mercury diastolic, you should think of an initial combination therapy. with a dual combination. If you can use a single pill with a dual combination, and if you are choosing a dual combination like that, the first choice should be either a ACE or ARB, ACE inhibitor or ARB, along with a diuretic, preferably, or a CCB in the first choice. In the second choice, if this doesn't work, then if you step two would be a triple combination, which can again be in the same pill. If you're using if you've used ARB, then you can go for CCB. If you've used ARB and diuretic, then you can add a CCB. Or if you used a ARB and CCB, then you can add a diuretic. And same with the ACE inhibitor. You don't combine ACE and ARB, but ACE or ARB can be there along with a diuretic initially and then a CCB. And then if that doesn't work, that is when three agents along with the diuretic given optimal doses are not working, then you call that hypertension as resistant hypertension. And there, the choice that we think of is adding spironolactone or adding a direct alpha or adding a alpha blocker or beta blocker. So that's where you would bring in either a beta blocker or a alpha blocker or spironolactone. Now, beta blockers have a specific role in patients who have got heart failure or angina post MI or atrial fibrillation or younger women who are planning pregnancy. In such situations, this is a specific indication for beta blocker, and you may go with beta blocker much earlier than considering them as a third line therapy. So, as we have seen, this is the recommendation from the European Society of Cardiology in as late as 2018. Now, if you look at the ACC-AHA, which came out in the later half of 2017, almost the same time, I mean, a few months earlier than the ESC guideline. And what they said was that they have given the recommendation, a grade 1 recommendation for initiation of antihypertensive therapy. First line agents include thiazide diuretics, CCB, and ACE inhibitors or ARB. So this is how they have put them in the first line therapy along with the CCB or a diuretic. If you look at the Indian guideline, let us look at our own Indian guideline. We have had 4 editions of this. The recent fourth edition of the Indian guideline, which came out in 2019, published in JAPI in October 2019, said that you have to stratify patients based on their age. The older patients have a different approach. Younger patients have a different approach. For the younger patients, it is A or B. A is ACE inhibitor or ARB, that is, or a beta blocker. For the older patients with hypertension, your first choice should be a calcium channel blocker or a diuretic. And once that is in the first step, if these are not enough, then you go to the second step where you combine this. That is, if you have started with A or A, you add C or D, or if you started with B, again you add C or D, and again in third step, then you combine the third agent. And if the three agents are not enough, along with the diuretic, three agents, particularly with the diuretic, are not enough, then you think of adding a drug like spironolactone alpha blocker or another diuretic. So this is how you have to approach the management of hypertension. And so if you look at the choice of ARBs in different situations, as you can see, between the ARBs, if you have to choose between the ARBs, as you can see again, Telmisartan has got a very important role. As you can see in patients for cardiovascular prevention, it stands out. Only other drug which has got some evidence available is losartan. Atrial fibrillation, again, Telmisartan has got better evidence as compared to losartan. Diabetes mellitus, again, Telmisartan has got a large amount of evidence available. Metabolic syndrome, again, you have got Telmisartan having good evidence. Valsartan is the next one, which also has potential benefits. When it comes to myocardial infarction, I think the more amount of evidence is available with Valsartan as compared to Telmisartan. But again, Telmisartan is close to Valsartan also. Again, there close second to that. Cognitive decline, again, Telmisartan probably has some evidence to say that okay, it may be working. For stroke, again, Telmisartan following following closely to losartan, and diabetic nephropathy also because of the IRMA and the other trial, that is, as you mentioned, the LIFE trial and the IDNT trial where losartan was used. So I think because of that, losartan comes first, and then Telmisartan is very close second. So what we have seen is that Telmisartan, as you look at it in different options, Telmisartan is a very good choice. It is probably the most widely used one, and rightfully so. It has a very important place in the management of hypertension amongst patients with diabetes. Now, the unique features of Telmisartan, as you mentioned, that it is very effective. It has got evidence for CV reduction. It has got the longest half-life. It has got lipophilicity. Because of it, it has got greater bioavailability. It has got unique action on the PPAR gamma system, and thereby it has got the effects on the endothelial functions, and it is preferred for diabetic hypertensive. It is probably the cardiometabolic sartan, which, as you can say. And if you look at some of those metabolic benefits that we see, it is in terms of improving insulin sensitivity, increasing the adiponectin levels, reducing the inflammatory markers, and reducing the cardiovascular morbidity in patients with atherothrombotic cardiovascular disease or type 2 diabetes with end organ damage. So it has got a convenience of once daily use, and it is approved for most of the indications of hypertension, and no dosage adjustments are required for elderly or with renal impairment, or even on patients who are going for hemodialysis. So with all these benefits, what we see is that telmisartan stands out as a very important molecule for the management of hypertension amongst patients with diabetes. Thank you all for the very patient hearing, and I would be happy to take any questions which are coming up. Mr. Patil is probably
Yeah.
the questions he may.
Yeah. Sir, thank you very much, Dr. Sai, for your such a nice and lucid presentation on the telmisartan as a molecule. And you have taken the entire audience starting from the journey of ARB till today. So there are few questions on the chat box. Can we go ahead with this question,
Yeah,
sir?
please,
Yeah.
yes.
Yeah. Sir, it is quite clear that we should continue with the ARB and ACE inhibitor in COVID-19 patient. But can we continue with the statins also?
Yeah, statins also should be continued, because the benefit that we have with statins, 30% reduction in cardiovascular risk is not seen, to be lost by stopping the statin, because there's a rebound increase in all these problems also when you stop the statin. So statins should not be stopped. The ACE inhibitors, the ARB, should be continued. We have got very good data right now available that has shown that the use of ARBs or ACE inhibitors does not interfere or does not cause any adverse effects on people who are using these molecules in terms of the COVID infection.
So there is another question is that what about choice of antihypertensive drugs in a newly diagnosed hypertensive with the COVID-19?
Yeah, if you are newly detected hypertension also, I mean, you can just go with the available evidence. As you've seen, the available evidence is very good with the ARBs. They are very well tolerated. They have a significant benefit on the mechanisms for the cardiovascular disease and the complications that happen with diabetes. So using ARBs, I think, should not be a concern when you are starting a newly diagnosed hypertension. If you have to start this in this COVID era, we would still continue using it, because now, I mean, earlier when the epidemic started and when we came to know that it was the virus entry was happening through the ACE2 receptor, at that time we had little concern whether we should start in newly diagnosed hypertension, whether we should start these drugs or not. But now it is quite clear from the studies that we have had that starting this drug also has no effect, no adverse effect.
Yeah. So there's one more question is that what is your experience of telmisartan amlodipine versus telmisartan selnidipine in terms of blood pressure control?
Yeah. So what we have seen is that, as I was mentioning, that most of the studies that we have with so basically the question is between telmisartan amlodipine versus telmisartan selnidipine.
Selnidipine, yes.
Yeah. So if you look at it, if you look at the molecules that are there today, we have telmisartan available for 22 years and losartan available for maybe 24 years, and that is the reason why we have a lot of data on these two molecules. Whereas if you look at azilsartan, although some studies have claimed that it is probably more potent or more effective in reducing blood pressure, but we don't have enough data on that as yet. We still need more data. We still need more studies on that. So similarly, with amlodipine, we have got a lot of data which has shown that it is a very useful agent. With selnidipine, although we have got some studies which have shown that based on its mechanism of action, it may be better off, it may have some advantages, but we still don't have that data available. That is, we don't have large data in terms of reducing cardiovascular events and all that. So using telmisartan with amlodipine is a good choice even today. And if your patient has got edema which is not coming when you're using cilnidipine, that may be an option that you may use it, because cilnidipine also causes edema in some patients, but although the number of patients who develop edema is lesser as compared to those who develop with amlodipine. So if that is an issue, then maybe you can use cilnidipine in some of your patients. But this is the way the evidence is available today.
Yeah. Sir, there is a one question from Dr. Hani Nishal.
Huh.
When we label as a resistant hypertension, and what is the treatment?
Yeah. So what we said was that resistant hypertension, we call resistant hypertension when hypertension is not controlled with three drugs. Three drugs used at optimal doses, not that you're using 20 mg of telmisartan and saying that it's not controlled. You should use at least 80 mg of telmisartan to say that, okay, it is not still not controlled with 80 mg of telmisartan, at least 5 mg of amlodipine, and also having one diuretic on board. So if you have one diuretic and two other agents and used at optimal doses and still the BP is not controlled, then you call it as resistant hypertension. And such people who have resistant hypertension, what has been found is that many of them benefit, although a large number of these, the proportion of these having defects in the, having adrenal, aldosterone as a major player for the hypertension is quite high, and so therefore we use a agent like spironolactone, which is an aldosterone antagonist, becomes a choice in that group of patients. And also the other options are alpha blockers or beta blockers.
Yeah. Sir, one more question. Can we prefer the calcium channel blocker, preferably the new generation like azilidipine, or the S inhibitor ARBs in COVID-19, which is a newly diagnosed hypertension patients?
Yeah, as we said that we initially, when the epidemic started off, we had this concern whether the using ACE inhibitor can actually increase the expression of the ACE2 receptor, and whether that will have a effect on increasing the risk for development of problems in patients who develop COVID infection. But what was seen from data from France and other places, when they've analyzed the data, they have said that even in patients who are using ACE inhibitors versus those who are not using ACE inhibitors, there was no significant difference in terms of the risk of rate, in terms of the severity of infection and the outcomes. So therefore, we became a little confident that we can still use the ACE inhibitors or ARBs. We don't have to worry. Those who are already taking, we don't have to stop them. Now, if you're seeing a patient who has come now, and even though you have a lot of data available saying that it doesn't cause, if you are still having a little concern in your mind, then I think even the newer generation calcium channel blockers, as you said,
Azilidipine
and all these cilnidipine, they have effects on the L channel, N channel, and all these all the three channels they block. So that's why they have better effects than amlodipine, and they are potentially good agents, and you can use them. They have been shown to have the benefits that are shown with the telmisartan also. Maybe after a couple of years, you may see some studies which have shown these benefits in large number of patients with the use of these molecules also. But today we don't have that much of data on these molecules. But mechanistically, we know that these molecules have that benefit, and you can use them also. You can, if you're more comfortable, you're not worried that this concern may be there, then I think it's better to use that, because this is more important. Getting through the COVID epidemic is more important. Surviving this epidemic is very important. And if you have a feeling that you may be putting the patient at risk, then I think you can use these newer drugs. But although there's no evidence saying that using ARBs is going to be harmful, even if you use ARBs, you're perfectly right in doing it. Because there are many ways of doing a thing, of skinning a cat, as you can say, many ways of skinning a cat. There can be different ways of doing the right thing. So if you're treating hypertension is most important, whatever way you do to treat, whatever measure means you adopt today, if you're right, then that's good.
Sir, one more question from Dr. Hani Nichal. The role of ARNI in hypertension with congestive heart failure.
Yeah, ARNI has become a very important class of drugs, particularly for managing patients with heart failure. So I think there's a lot of data on this, and I think we need to use, with the availability of these drugs, we need to use them appropriately in patients who have got heart failure, particularly those hypertensives who have heart failure. There is a need for using this. The combination of valsartan sacubitril is definitely a very good choice in these patients.
Yeah. So one more question. Yes, inhibitors many times themselves leads to the dry cough, which may be taken mistaken for actual symptom. Should we prefer more ARB?
Yeah, so as we know that ACE inhibitors have this problem of cough, although it may be there in a certain percentage of patients, but it does become troublesome in some patients, the dry cough that happens with ACE inhibitors. And what we've seen is ARBs don't have that disadvantage or the side effect. It can still occur in a small percentage of patients with ARBs also, but certainly much less than what happens with ACE inhibitors. And that is the reason why we today prefer these the ARBs. And we have shown these studies basically because the ACE inhibitors had a lot of evidence available because they were introduced much earlier. They were introduced, at least we spoke of losartan being introduced in 1998. ACE inhibitors came in 1990s itself, the early 1990s. So at least one decade earlier than the ARBs. And there was a lot of data on the cardiovascular protective effects, with whether you look at captopril or whether you look at ramipril, or enlapril also. So because of that, what we have is that these studies were conducted which compared the ACE with the ARBs, and now they've shown that ARBs also have that benefit, and therefore we are now using them more often, because we know that they cause less side effects and they can be comfortably used without having the fear of these side effects.
Sir, the last two questions of the today's seminar. The 60-year male, history of smoking, he is on telmisartan and S-amlodipine for hypertension. Now the blood pressure is well controlled. So at present COVID-19 situation, any change of medication is required?
Absolutely no. We have got evidence that there is no need to change the medication. Just continue the same medication. His blood pressure control is very important. If he is maintaining his blood pressure control well and stopping the smoking also, that will be good. Actually, now you should advise him to stop smoking in this era.
Yeah. And this last questions of the today's webinar, sir. How to manage the non-dipper?
Non-dipper. Yeah, so non-dipping is actually, first identifying the non-dipper is very important, because we may not identify because they may have blood pressure which is normal throughout the day. So doing a nocturnal blood pressure measurement, either doing it at night by a machine or, that is very difficult. So having this ambulatory blood pressure monitoring is very important. And by that only we can identify non-dipper. And non-dipper is the one who is otherwise appearing normal, but he's at a high cardiovascular risk. And these patients can be addressed. This issue can be addressed very often with lifestyle measures itself. Stopping smoking, as we discussed just now. There was the other patient who was smoking. All these things increase the obesity and all these things, and poor sleep hygiene. All these actually produce this non-dipping. If you are able to control all this, then you can actually bring about a good relief in these patients. Otherwise, you have using antihypertensives early is important in identifying those non-dippers, and using a night dose of medication. Using the night dose of medication is again a very important factor, because it helps in controlling those with non-dipping hypertension, and also those who have got cardiovascular events, because we know that cardiovascular events happen at a greater frequency early in the morning. Using antihypertensives in the night is very useful from that time.
Thank you very much, Dr. Sai, for your once again for the all questions, all elaborate details. And
Mr. Patil. Thank you, Mr. Patil, and thank
you.
Sir,
can you give me 1 minute? Sir, can you give? Yeah. So once again, on behalf of entire Torrent Pharma, I take this opportunity to express my sincere gratitude to all of you. Even your expertise and suggestion will be certainly help us in our new endeavor. Sir, the valuable inputs and views shared by you in this virtual webinar will definitely help us to chart our future course of actions and thereby strengthening our position in the cardiology segments. So once again, thank you, all of you, and hope your support to the Torrent tool remains in the days to come. So thank you very much, Dr. Sai, once again, and I officially conclude the today's webinar.
Thank you.
Thank you.